Okay, go ahead. Now we can go.
Fractures.
Fractures. So what kind of fractures are there?
Transverse, spiral, green stick, common unit, oblique, pathologic, and stress.
Mm-hmm. Is there another way that you what's another way to classify fractures?
Open, closed.
Okay.
Complete.
Complete versus incomplete. All right. And how, when we're talking about fractures, orthopedic injuries, what sort of complications?
Compartment syndrome, but that's not a complication of fracture, it's a complication of immobilization.
Oh, okay. But well, I guess in my mind, I kept it in that, in that, in that, in that family. And so what are some of the things that you think about when you're talking about?
What do you mean, green stick?
So what, I'm sorry, what's a green stick fracture?
Incomplete fracture with the periosteum actually intact, mostly in kids.
Yeah.
Yeah, because their bones are still growing. So you
They'll
think
flex.
about it like a sapling that's easily bendable.
Good.
Carolyn,
yeah.
I want to clarify something. Maybe everybody will benefit from that. So the definition of comminutive fracture with 2 or more fragments.
Yep.
But any fracture leaves us with 2 fragments at least.
Point well taken. But I guess it's right. But I guess it's, so I guess you would say more than 2 pieces.
More. So except those 2 big ones, like additional ones. Yeah, that's how I took it. Because
yeah.
If it's a complete fracture, that 2 fragments always.
Yes. Yeah.
Okay.
So we were talking about compression syndrome, and what sort of things do you look at, like from an assessment perspective? Do you look for?
Caroline, excuse me, were we speaking compression syndrome or compartment syndrome? I'm sorry.
Compartment syndrome. I'm sorry. It all begins with a C. I know. I'm sorry.
That's all right.
Yes, compartment syndrome.
6 Ps.
The 6 Ps. And so what's your patient going to?
Pain, paresthesia, pressure, paralysis, pulseless. What else? Did I forget anything?
Pulselessness,
Pulselessness.
paralysis, pressure,
Paresthesia.
paresthesia, pallor, and pain.
Yep. Okay. And all right, so that's compartment syndrome. What other sort of complications might we look for?
Closed reduction or open reduction?
Complications, James.
I'm sorry.
The most terrible is fat embolism.
Okay, and what are some of the signs and symptoms of a fat embolism?
Close.
Similar symptoms to like a
Pulmonary.
yeah, DVT,
Not
PE.
not PE, more likely, Katie, PE. And so what's
Yeah, okay.
that look like?
So rapid breathing, shortness of breath, lethargy, confusion.
Anything special about fat embolism?
A late sign is petechiae of the upper body.
Very good.
What was that, Carolyn? I'm sorry.
Petechiae of the upper body is a late sign of fat embolism.
Thank you.
Um, Yep. And in terms of, this really isn't a complication, but an assessment. And any other fractures, you get a little old lady who comes in after a fall.
Fractures,
And what do little old people break when they fall?
Hip.
And what's that? What did I say that could look like?
One leg will be shorter than the other.
And often,
Externally rotated leg.
correct.
There you go.
There you go. It's so classic.
Yeah.
Um,
And sometimes they don't even feel it. They don't even know that they have a broken bone.
until you move them.
Yeah. But it's just weird. You know, so many broken bone, they're not even aware of it.
Yeah. No, that's not completely, again, as long as you don't move, most people, they're unaware that there's a problem often. It's when you go to ask them to do something that the problem seems to escalate. And somebody said something about open fractures. It's one of the biggest risks.
Infection.
Infection.
Good. I believe that, let me just check to make sure. And just, again, we talked about compartment syndrome, you talked about fat embolism, we talked about infections. Any other complications that can come from an orthopedic injury?
Potentially bleeding, hematoma,
Hematoma, possibly, yep.
nerve damage.
How about some of those hazards of immobility?
Impaired physical mobility,
Yeah, but what comes from that, Jack?
falling, risk for falls,
Risk for falls,
Atelectasis.
atelectasis, Kristen, stay on that. So atelectasis, what are some of the hazards of immobility?
Pressure ulcers.
Clots.
And issues, right?
Thromboembolism.
That's right, DVT, thromboembolisms. Good. And you said I think you said neurovascular, Eugene. Let's say, and so your patient comes back from being casted. You can't palpate a pulse, you've got poor cap refill. pain, not responsive to the pain meds? What do you need to do?
Doppler to see the
Yeah, Doppler to check to make sure you're not just missing it.
Call the physician.
Call the physician and get ready for
Remove the cast.
probably splitting the cast, yes. Okay.
interventions.
All right, I think we've covered ortho.
Do we have interventions or no?
You talked about most of the interventions.
All right.
Moving on to cancer.
Wait, did we skip over the nursing diagnoses for ortho?
It was mentioned,
Okay, thanks.
maybe not in specific terms, but the correct topic was mentioned. Okay. So, cellular changes. What makes a cancer cell a cancer cell?
Abnormal
So it's
growth.
no longer producing properly. It's somewhere along the reproduction cycle. So it is either overproducing or producing improperly. And then subsequently, the future cells are not, they're not proper cells.
And then I think what you said was correct, Kristen, and then somebody started to say something else.
I just said abnormal cell growth.
Yep. Anything else in particular?
They lack differentiation. So they're able to metastasize and invade other areas.
Well, again, you know, that's one of those things you need to look at. Some lack differentiation, some look more like the host cells, but they're definitely different from the local tissue that they're supposed to be. That's for sure, Linda. And those malignant cells have specific antigens as well, right? How do we work up cancer? How do we get a definitive diagnosis?
Biopsy.
Good. What are some initiation risks?
Radiation, chemicals, viruses, sunlight, smoking, or alcohol.
Genetics.
Good.
Curses and spells.
What was that, Gene?
No, just kidding.
Oh.
Curses and spells.
Curses and spells.
Witchcraft.
Sometimes that seems. All right. Staging and grading systems. There are many out there. What did we talk about in class again?
E&M system.
What's
That's the
that stand for?
tumor.
Tumor nodes metastasis.
Oh, yeah, you're right. Awesome.
Yeah.
Let's see. All right.
Carolyn, what level of detail in the TNM? I mean, do we have to go the TX, the TO, TIS, or what?
I'm getting ready to move on to the next topic, James. Please don't
Lovely.
interrupt me.
Thank you.
Does that answer your question?
It does. Thank you.
All right. What are some of the surgical interventions that a patient might expect?
Biopsy, excisional biopsy, debulking,
What's that, Jack? Debulking?
removing the bulk of the tumor when it's possible
Mm-hmm.
to try and restore function. There's also preventative, curative, and then palliative and reconstructive.
Mm-hmm. And okay. And what are some of the complications we talked about with from tumors that can happen? And I talked about one thing in particular in class.
Tumor lysis syndrome.
Yeah, that wasn't the one I was thinking of. We'll come to that one also, but you're right. We did talk about that.
Was it syndrome of inappropriate ADH?
No, although you should probably know that one also.
Maybe affecting, without metastasis, also affecting the functioning of the tissue surrounding it, like certain brain tumors.
That's good, Kristen. Yep. That as tumors get larger, they can affect the structure and the function of the tissues around them. And again, I spoke of.
You mean cachexia? No?
Again, that is a real issue, but that's what I was thinking of. Happens in lung cancer a lot because of the lungs adjacent to all the venous structures.
Superior vena cava syndrome.
Yeah. Superior vena cava syndrome. And what does that look like?
Facial edema, periorbital edema, distension of the veins in the head, neck, chest,
Mm-hmm.
seizures, and a headache.
Good.
That was superior vena cava syndrome, right?
Yes.
Yeah.
Okay.
And I know Jean had sent me the slide that had the different goals of treatment, and I'm not sure whether goals of treatment was necessarily the right description, but what's one of the, so what are some of the treatments that we use for cancer? We already talked about surgical interventions where
Radiation and chemotherapy.
Radiation, chemotherapy, and
Also palliative measures, just pain measures and whatnot.
yeah. And why do some patients potentially have all 3 or 4 types of treatments for them, for their cancer?
basically just trying to figure out what works, because even though cancers can fall into categories, they can still be different even amongst similar cancers. So something that works for one patient may not work for another, because with cancer treatment still, even they're just kind of a lot of the time just throwing everything at it, like what's going to work.
Or and partially that's true, but also, well, maybe they've got a large tumor somewhere. So they start with radiation to shrink it, make it more susceptible to chemotherapy. Then they get chemotherapy going, and that does its trick. Then maybe they're going to use a biologic for long-term control of the cancer. So each different therapy is going to offer some benefit. Sometimes it's in anticipation to make the next different type of therapy work. Does that make sense?
Yes.
Caroline, is stem cell considered the same as immunotherapy, or they're different?
No, that's different. Stem cell is actually considered transplant.
Okay.
You're getting tissues from another individual that needs to go through, and I am in the process of putting together those cheat sheets for the areas that we didn't go over, stem cell being one of them. But you know, you need to be typed and cross-matched, and all of those same transplant processes need to happen for stem cell. And what's true of any transplant, whether it's a solid organ or stem cell, as I said, you know, I think I talked about this briefly when we were talking about blood transfusions. And blood transfusions are matched at essentially the highest levels. You know, what your blood type is and what your Rh factor is. And there may be other things that they check in the lab. But when it comes to tissue matching for transplant, there's quite a significant list. I think, Eugene, and you can correct me if I'm wrong, isn't there like over 70 different proteins and antigens that they match, that are checked for transplant matchability? And
I never dealt with that, but you're right. So there are way more than blood. So many.
Right. And
yeah.
Not every single one needs to match dead on, but the more that match, the decreased chance of rejection.
The better prognosis, yes.
And a better prognosis, right? Because it's not only, you know, once you're transplanted, and yes, you still need to worry about infection, you still need to worry about many things, but what you really worry about is rejection. So, and again, matching for transplant, whether it's stem cell or solid organ, is a much more complex business than a blood transfusion. All right, let's see. I think we're on oncologic emergencies now. Okay. That one we already got. That one we already got. Eugene, you had mentioned tumor lysis syndrome earlier.
Yes.
What is that?
That's the syndrome of when the tumor is susceptible to radiation or chemo and actually dissolves rapidly. So in all of those waste products like purines, urea, calcium, so all injected into the bloodstream, and it may cause
Right.
so electrolyte imbalances.
Great. And you said uremia or uric acid levels. So during that, when you start that chemotherapy or radiation to treat a tumor, you're drawing electrolytes at regularly scheduled intervals and looking at electrolytes and, as you said, uremia, uric acid levels. Very good, thank you. And when we're talking about oncologic emergencies, was there sort of an overarching organization or types?
There's
Oh.
obstructive, metabolic, and infiltrative.
Thanks, Robin. You see, you say something so nice and clear like that, and I want to say thank you for listening, but you could have just read the slides too. But either way, thank you. All right, so external beam radiation. What are some of the side effects that patient might complain of?
Inflammation of mucosal membranes and tissues everywhere, wherever it's irradiated. Mucositis, pulmonitis, and all itises.
Yeah. And in general, how might a patient feel? And this may be true to any cancer patient, whether they're getting radiation or chemotherapy. Almost every cancer patient I've ever known.
Extreme fatigue and nausea, vomiting.
There you go, Kristen.
Abdominal pain.
And I don't know, ladies, when you get a little older, you'll understand this. There are not many women who in moments between good friends, they don't admit that they're freaking exhausted all the time. Guys, I know you're working hard. I know you got lots of balls in the air, but when it comes to, studies are pretty clear that women still do more than 50% of the work around the home, maintaining the family, maintaining the house, as well as working outside the house. But then you talk to women who have cancer already, and they'll say, holy crap, I didn't know what tired was till I got cancer. I thought I was tired, but now I know tired. So almost everyone will talk about fatigue, whether it's chemo, radiation, or the cancer itself. God, that was a long story, sorry. And again, this is a little more specific to external radiation. What's one of the body systems that's particularly impacted?
Skin breakdown?
There you go, James. Yeah, changes to the skin, which then leads to what do you think?
Infection.
How'd the infection get in?
Through the pores, so
Breakdown.
break in the skin.
Yeah. Impaired skin integrity, if you will, right?
Love that.
Sometimes with mistakes and planning, so it even can be radiation ulcers which don't heal at all, so they need to be surgically repaired. But that was in the past. Now with modern planning systems, so it almost never occurs.
Well, and that's why I was giving props to the radiation oncologists, because their calculations are critical to preventing wounds like that. But is it fair to say that that skin that has been subjected to radiation is at risk for poor healing in general?
Definitely.
Yeah. What about somebody who's got an implant? What are some of the, whether it patient, family, education, or even just planning care, what do you need to be aware of?
They're radioactive, so you want to limit time around them and sort of try to limit visitors as well.
There you go. Very good. And Kristen, you already mentioned one of the most common side effect of chemotherapy.
Nausea and vomiting.
Yep. And then another side effect are those, the fact, what are some of the other side effects of chemotherapy?
Potentially losing your hair,
Yep.
including like your eyebrows, your eyelashes, everything, not just the hair on your head.
Not always, not with all the drugs. But
Not always.
That's why I said sometimes, yeah.
yes, yes.
But it's for
Carolyn, was that under radiation or chemotherapy?
Yes, James.
Both? Okay, thank you.
Keep going on the side effects of chemotherapy.
Bone marrow suppression, that's the biggest one.
And then, so what happens with bone marrow suppression?
Pancytopenia, so all blood cells are down.
So
mostly white blood cells. Yeah.
Mostly white blood cells, which is why a lot of Neulasta, and I'm sorry, I don't remember what the generic name is given to support or to re-stimulate.
Like filgrastim.
Filgrastim is, there you go. Thank you.
One of those.
Yep. And so when we have, so we've got, as you said, pancytopenia, but we'll have neutropenia, which are the white blood cells. We'll have, what's it called when your platelets are down?
Thrombocytopenia?
Cytopenia.
Cytopenia.
And what are those signs and symptoms? What might you see?
Ecchymosis, petechiae,
bleeding.
bleedings.
I heard ecchymosis. I heard bleeding.
Petechiae.
Petechia?
Purpura.
Purpura?
And so, yeah. What do you avoid? What do you avoid doing to these patients?
Rectal temperatures.
Rectal temperatures are for what we worry about, what blood cells with rectal temps. Although I guess you're right. I'm sure thrombocytopenia, you really don't want bleeding from below either. That's true.
You're also at risk for infection there because of the fecal matter going through the broken skin.
That's what I thought of it initially, but he's right. You also don't want bleeding down there also. What's another common place for bleeding for people who are thrombocytopenic?
In the mouth?
Yeah, they can have some gun bleeding. Again, dealing with the face, where else can you have bleeding from?
Nosebleeds?
Yeah,
Nosebleeds, yep. Anybody got a fancy word for that?
Epistaxis.
Epitaxis.
Good. Okay, and let's see, one more. So, Kristen, you said one of the most common side effects is nausea and vomiting. So what do we need to do for that patient?
Pre- Pre-medicate for it.
Beautiful. So with a patient has not received their bone marrow transplant yet, or their stem cell transplant yet, but they're getting ready for it. They're in what's called the induction phase. I don't know, did anybody read that PowerPoint yet or read that part of the reading? What's the biggest risk at that point in time?
Infections.
Yeah, infections. And so what they do to get a patient ready for a stem cell transplant is they purposefully shut down the patient's bone marrow, because they've got some sort of bone marrow cancer, some hematologic cancer, and so they want that patient's body to just stop making cells. And so they give them all sorts of chemotherapies to just shut it down. And that usually takes, I don't remember the time frame, but that patient is literally without white blood cells purposefully for a period of time. It also prepares the patient to receive the new healthy stem cells, and hopefully, because there's no other cells floating around, there will be a time frame where the transplanted cells can sort of re-stimulate the bone marrow themselves, get it restarted back on track, and not suffer early rejection. But at that point in time, the biggest risk is infection.
So in our notes and on the PowerPoint, we didn't refer to it as induction. The phases that we had were conditioning, stem cell infusion, neutropenic, engraftment, and post-engraftment. So would that be the neutropenic phase?
It would be the conditioning.
It would be the
They're
conditioning.
actually neutropenic for a really long time.
Okay.
Okay. Right, let's see. When we're talking about HIV testing, how do you interpret results?
Positive, negative stages of disease.
Okay, positive, negative, or stages of disease. And what does it mean to be positive HIV?
Your body has produced antibodies against HIV.
Excellent, Katie, very good. And then what are sort of the two, I know, I remember the graph of latent stage and things like that, but, once you've tested positive, what's the next, if you will, big milestone?
AIDS?
And how do we define that, James?
I'll be frank with you, I just don't remember.
When you have a
More levels are less than 200.
200, yeah. CD4.
Kevin, just say that one more time, please.
Your CD4 levels are less than 200.
There you go. Yep. And Kristen, you said it also. I just wanted one person to say it clearly.
There you go, Kevin. Thank you.
Yep, it takes a village. That's why we're all here. All right. When we talked about antiretroviral therapy, what are some of the important things you need to you need to know and remember and help your patients with?
Strict adherence to the medication plan.
Yep.
Regular testing.
Let's go back to the adherence for a minute, Eugene, and like many things, this is not a yes or a no per se. Just because we think a patient has high risk for poor compliance, what's our obligation, or what should we be doing?
Trying to find ways where that you can ensure compliance, like watching them take their meds.
Mhm.
Educate them.
Educate them. This isn't necessarily a nursing or a medical thing, but if you're talking about quality systems and things like that, Deming, who's like the great father of quality management, one of his great quotes is, variation is the enemy of quality. And so what he means is, you want to build in consistency. So helping the patient build consistency into their life, which for some of these patients is, a stretch too far, or you need to do it in baby steps first, but helping them figure out how to be more compliant. You don't just walk away going, oh, well, oopsie, sorry. Doesn't also mean that you start treatment, but you still do your best to help them. So let's see, signs and symptoms of HIV encephalopathy.
Confusion, decline of cognitive functions, unexpected.
Yep.
Until it's diagnosed. Yeah.
I don't know if I told you, I might have told you this story when we were talking about dementia in the spring, but we had a guy on the unit. Oh my God, he was not only miserable, like just not very nice at all. He was combative, he was physically aggressive, he was verbally abusive. He was a tough nut, man. Oh, and you didn't feel safe around him. We always had, you never entered his room alone. You always went in with somebody, and if you could go in with whether it was a resident or another guy. That's why I always tried to make sure my travelers were guys, because it was nice to have. I tried to hire guys also, don't misunderstand me, but never felt safe. And as his disease progressed, we started seeing increasing signs of HIV encephalopathy, and he was becoming increasingly nonverbal, which of course, being the weasels that we are, we're like, well, at least he doesn't swear at us anymore. Could be worse. And I have to say, he got increasingly sweet and docile, and he smiled for the first time in a couple of years. I mean, it was just so bizarre. And then he essentially, as I said, got nonverbal, but he was still physically very strong and active. And he would just pace around the unit. And again, this would never happen today. We used to put a sign on his back that said, if he leaves the 5th floor, call this extension. And he would just like kind of roam through the South Pavilion and the East Pavilion and go up and down the elevator. And if he got too far, we'd get a call and we'd go down and get him and say, oh, come on back upstairs. And he really got so much easier. This is terrible to say, easier to work with. And you know, I honestly, on some level, I'm not sure which was his true personality. Was he really as mean as he was when he was verbal? Or was that just what he needed to do to survive in the life he was living? Or was he really just a nice, sweet guy? He had circumstances, both within and without his
Or like hurricane that me.
drove him to it. But gosh, he was much easier to deal with once he became completely encephalopathic. Let me tell you. Isn't that terrible? Oh, I'm going to go to hell. I don't know many people there. What the hell? All right. So, okay. So I think that's it on HIV.
For determining effectiveness for antiretroviral,
Oh, yeah. Thank you.
is that like a lower viral load and a higher CD4?
Exactly, Robin. Perfect. Thank you.
Cool, thanks.
Why did you say that it would never happen now, so that you put a sign on his back? So that's pretty effective way of dealing with that, I would say. And
I
it
don't
doesn't
know. I
hurt
think
anybody.
that's that people would somehow find that offensive or intrusive or some violation of HIPAA or something like that. But
I mean, no, we give patients cards like the ones who have like BRCA and Wernicke's issues. Like if they get lost in the community, you know, when they're independent living, we have a card that says who they are and to call this number if they seem confused. So I don't know.
my father once gave my mother an ID bracelet that had her name, her phone number, her address on it. And I was just, you know, she was, I think, she was 70. He was probably, so that made him like 71, 72. But she actually found that quite romantic and thought it was the most romantic thing he had ever done, because if she got lost, they'd be able to get her back to him. I'm not exactly sure that was his purpose, but it was still pretty cute. But I don't know. I'm not sure. There's a lot of things we used to do that I'm not sure would be as well accepted. We had huge drug using issues on the floor. As much as we would say, please don't use illicit drugs, if we did. And we used to do all sorts of things like, we'd send patients down for tests that they weren't ordered for so we could search their rooms. We'd say we're getting an admission in and we needed this room just so we could move their stuff and see what happened, see what contraband they might have had. I'm not sure that would all fly as easily these days.
I don't know. I've sent people out for ice cream when we've had to do that and with certain populations in like group homes. Like, oh, somebody want to go for ice cream with somebody?
Goes on. We actually found for a while there, the largest drug bust in the state of Connecticut took place on my unit. We found millions of dollars worth of cocaine, heroin, and weed in the ceiling of one of our patient rooms. We knew that there was weird traffic. We knew there was something going on. We had sent this patient everywhere in the hospital. And then one day we were sitting there trying to figure out what was going on, and Patty Joyce noticed one of the ceiling tiles was askew. So there we were. I know Laureen Reinhardt and I are lifting Patty up. We don't bother to call anybody. Don't bother to get a ladder. No, she's climbing up on our shoulders and she's pushing through, and you can hear her go, holy fuck. And we closed it all back up, and then we called security, and we had DEA on the unit for probably 6 to 8 weeks, undercover, trying to watch patterns and who was delivering, who was selling, who was what. It was pretty amazing. All right, let's move on. TB. So what are some of the signs of active TB?
Night sweat, cough, fatigue, weight loss.
Anything else?
Fever.
Off for 3 or more weeks, and it may have chest pain,
Fever, night sweats. Oh,
dyspnea,
this is a big one.
weight loss,
Weight loss, he mentioned that. What, this is something he didn't mention.
hemoptysis,
There you go, Linda. Hemoptysis is a big one.
But that's usually late stage.
Okay, I'm not going to argue that, but it's kind of a classic
Yep.
active TB. And then the flip side is, what are some of the signs of, I could say, what does it mean to have latent TB?
Be infected but have no symptoms.
Correct. How's the patient usually feel?
May feel okay. May feel okay.
Yep, no symptoms, right? And what happens with TB testing?
Chest X-ray doesn't show granuloma.
And what other
cultures will be negative.
What was that?
Cultures are negative in latent, but they're positive and active.
Correct. And we'll get to cultures in a minute. Remind me, Linda, to just talk about that more. And what's the other big test that we do for TB?
They'd have a positive PPD.
They would have a positive PPD, Jonathan, correct?
Positive quantiferon.
Yeah.
Now
And
we have this more
is
sensitive test what we got for SIME, I mean, as a prerequisite.
right. Is a patient with latent TB infectious?
No.
Correct. Linda, you mentioned cultures. What kind of cultures do we send for pulmonary TB?
Good question.
Well, so in most cases, at least for pulmonary TB, we send sputum. I guess the better question would be, what are we testing that sputum for?
Acid fast bacteria.
Acid fast bacteria, AFB, acid fast bacteria. And you get an early morning sample 3 days in a row. And like all sputum samples, it needs to be what we call a quality sample. It needs to come from deep. We don't want, just a back of the nose post-nasal drip loogie that we spit out of the mouth. We want something that comes from deep in the lungs and is coughed out. And it can, we can get respiratory therapy to help get a best quality sputum if necessary. How do we treat patients who have suspected TB when they're in the hospital? Is there anything in particular we do for them?
Airborne precautions.
Yeah.
Very good.
I actually had a question about that.
Yes.
So in one of our ATIs, it says that a patient with airborne precautions needs to be brought to a test somewhere. And it said that the answer was just to put a surgical mask on them. Is there a reason why the patient themselves would be wearing a surgical mask as opposed to an N95?
Because
Yes, Jonathan, there
they're
is.
worried about out, not what they're getting in.
No, that's not, no. Why haven't you guys been issued N95 masks?
Well, we have been, but we weren't supposed to because you have to get
fitted.
You have to get fit tested. And so you don't fit test patients, so you don't say you don't waste an N95, but an inappropriately fitted N95 is no more, no less effective than a surgical mask, Jonathan. Does that make sense?
Yes, thank you.
No worries. Good question, though. Any patients in particular, any people, what populations are particularly at risk for TB?
Prisons, group homes, and senior facilities, anything where colleges, anywhere where people are living in close quarters.
Yeah, anything else, Kristen?
Homeless, drug addicts.
Immunocompromised.
Immunocompromised, good. Good.
Would people who traveled to or come from countries with endemic TB be?
Yes, also. Very good. All right, so and what sort of education do we want patients to have to help them prevent spreading the disease?
Strictly adhere to the medication plan.
Yep, strictly adhere to medication plan. Good.
Avoid large crowds.
Okay.
Should family and contacts be like tested, isolated, etc.?
Well, they're probably tested initially. You know, they pull tuberculosis is a mandated reportable diagnosis through the public health department, and they will do contact tracing. That's on some level, you could say, one of the great tragedies. Although the system would have been overwhelmed by COVID, contact tracing is done for many diagnoses nowadays through public health. It's not an unknown system to us. We don't freak out when people, we contact trace for TB. We contact trace for many STDs and things like that. And some things are that we need them to know seem like more common sense things that you've been learning in school in terms of
Wash your hands, cover your cough, cover your sneeze.
Yep.
Throw your tissues out.
Yep, exactly. And again, people are told to, if once they're discharged, they're told to, isolate until they have X number of weeks on their medicine under their belt. They're told to isolate within their home, within their, for some period of time. So it's not like they get diagnosed at the clinic, they're handed their antibiotic and go, all righty, good luck. We'll see you in a couple weeks sort of thing. But, they are taught.
Is something on there about how they will show some positives for certain TB tests, some for the rest of their life? Like with the skin test and whatnot, and they'll have to get the other tests like the x-rays?
That's true also. I hadn't thought about that because it didn't work into the question, but that is true also. Okay. All right. Moving into GI. What are some of our physical assessment signs and symptoms of liver disease?
Jaundice.
Jaundice.
Edema.
Where?
Ascites.
Ascites, yeah.
Yeah. But specifically, James, where does that edema start?
Ascites would be around your abdominal area.
Right, but that, were you thinking ascites when you said edema?
No, I was thinking about lower extremity edema.
Thank you. That's what I thought you were thinking about.
Okay.
What other physical?
AST, ALT levels, like your liver function tests.
Are they going to be up or down for the most part?
Up.
Good.
Eye abnormalities, ataxia, confusion.
Dark urine and light stool.
Yeah. What's another A word?
Ataxia.
Asterixis.
Okay.
Encephalopathy.
Yep. The asterixis goes hand in hand. So you talked about liver function tests in more advanced liver disease. What other labs are you going to be looking for?
Bilirubin.
Bilirubin.
And then if it's advanced, albumin level is down.
Albumin is down.
And if it's advanced, ammonia level up.
Yeah. One more. Well, one more group.
ALPs.
Clotting factors, AP.
Coagulations, right?
Yep.
Are we talking PTINR, that sort of thing?
Yes.
No.
If somebody did have altered coagulation studies,
They'd probably be on warfarin because it's vitamin K is for the liver. No, or no.
well, no, let's
They have low vitamin K, so they're not going to be clotting.
right. So vitamin K would be an antidote for them, if you will. When might we? So for people that have taken excess warfarin, whose INR is severely elevated, vitamin K is an antidote to that. You get that, Kristen?
Yes.
And for a patient who is a liver patient who just has elevated coagulation studies because of their disease, it's not unheard of. Again, if a patient has to go for some sort of procedure, or let's say you had to take an IV out, you have to take an IV out of a patient. So what do you need to do for that patient?
Hold the site for 5 minutes.
Hold the site. It doesn't stop. I have the hiccups all of a sudden. All right, it doesn't stop bleeding. What might be an intervention for that patient?
Patch red blood cells.
Let's hope we don't have to transfuse them too soon.
Lactulose?
What's lactulose got to do with their bleeding?
Well, I don't know. I'm trying to stop the bleeding, right?
That's why I'm saying you got to stop the bleeding. What's going to stop bleeding? What did I just?
Vitamin factors, so vitamin K.
Vitamin K, yeah. They'll actually give vitamin K to patients with liver failure with elevated or prolonged clotting studies, yes. Okay. All right, moving on to pancreatitis. What are the labs that we look at for pancreatitis?
Lipase and amylase.
Trypsin?
In blood,
Yeah.
lipase, amylase.
And again, depending on what the source of the pancreatitis is, it might be bilirubins also, but amylase and lipase are a really good place to start.
And liver function too?
No,
Or no? Not always.
no. So somewhat similar to cirrhosis of the liver, what's another, is there a risk factor that pancreatitis shares with liver cirrhosis?
Alcoholism.
So our recommendation to those patients is,
Stop drinking.
Stop drinking.
yeah, but they're just not there yet.
Cut back.
What can we encourage them to do, even if they're not necessarily ready to?
Go to AA, and there's also medications they can take that will curb cravings.
Mhm. Kristen, I just found out about, there's another group, and I wrote it down somewhere, that has a somewhat different philosophy from AA, but is another community-based group.
Is it one of the religious ones?
Well, I was going to say, the person who was telling me about it, and I haven't had a chance to look it up yet, is sort of based on Buddhist spirituality.
Huh, interesting. There's other ones too. Like I used to go to Red Road, which is based on indigenous culture.
Okay, I'll have to look it up and see. All right.
Is that the refugee recovery? Or the refuge recovery?
I think that refuge recovery, I think that's it. I just was having a conversation with somebody yesterday and I wrote it down and I just didn't get.
Yeah, that one's a Buddhist inspired one.
Yeah, that's it. It doesn't get the media play that AA does, but this person found it very helpful. And whatever you can do, right? All right, so moving on to cholecystitis. What are some of the labs you might see altered in cholecystitis?
Alkaline phosphatase
And
bilirubin.
oh, and what? I'm sorry, what was that, Eugene?
Bilirubin.
Bilirubin, right? Okay, there we go. You know me, my hearing's going. And where there is elevated bilirubin, what do you also see in those patients?
Jaundice.
And where do you see signs of jaundice?
Sclera?
The sclera.
Could be the mucous membranes, like of the mouth, or the palms of the hands,
And
or stool or urine.
yeah, and just, the overall pumpkinoid effect. This is their time of year. They fit right into the background. So we've got a patient who's got cholecystitis secondary to gallstones. What might you anticipate for treatment for this patient in this day and age?
Cholecystectomy, a lap chole specifically.
Very good.
This retrograde pancreatocholangiography, where they try to catch those stones with this sort of mesh and the basket and pull it out.
Oh, really? I thought you were going to talk about the where they try to pulverize the stones with laser or with ultrasound.
Yeah, cholelithiasis.
Cholelithiasis, yeah.
Yeah.
Is it still in use? Because I remember many years ago they were using that, but then they stopped because you get, like, very soon you get the gallbladder full of stones, because that the sand which produces actually serves as a starting point for other stones.
Right. It's like they called it the pearl formations. The sludge ended up. Now you have many pearls of stones. Yeah. Lithotripsy. That's it.
It works well for kidneys because there is like a constant flow of liquids, but not for as I've heard.
Gallbladder.
For
I saw a lithotripsy van on the road about a week or two ago, and I hadn't seen one in years. All right, and what are two common tests that we might do for gallbladder tests or procedures?
Ultrasound first.
Ultrasound.
ERCP, MRCP.
And what do we worry about ERCP?
Pancreatitis.
And what comes with pancreatitis, Jonathan?
The necrosis?
As bad as that is to the patient in the immediate moment, what's their problem with pancreatitis?
Pain.
Pain. All those people are often in agony. And it's very difficult to control. It takes a lot of good, high quality narcotics. All right. All right, electrical burns. You get report your patient's had an electrical burn, or they're coming in from the community after an electrical burn. What's one of the first things you do for that patient?
Don't touch them.
Don't touch.
Well, so if they're still connected to the source, that's true.
Ground them.
But what what did you say, Eugene?
Ground them.
Ground them.
I thought you said drown them.
No, ground.
That's what they do in Russia.
Yeah.
Oh yeah, in Russia there are many effective methods.
So like check for signs of circulation and then prevent shock. So cover the affected areas and burn sites with sterile gauze or a clean cloth.
Yeah.
First check the pulse. So if the heart's still working. So I mean, like ABC.
So if the heart's still working is key there. So what do these patients need to be on?
Cardiac monitor.
If they're going to live to tell about it, they've essentially just been defibrillated. And this will come on the the cheat sheet, but with electrical wounds, burns, you're always looking for an entrance and an exit. In some ways, it's bizarrely like a gunshot. You look for an entrance and an exit wound. And if you find them and they've gone across the chest, that patient's essentially been defibrillated with some level of electricity. So cardiac dysrhythmias is a significant big deal. An electrical burn, now this is an aside, this will come on the cheat sheet, more information than you need to know for the test, but electrical burns are very deceiving initially. They'll have a relatively small wound, it's usually red, maybe not open. They'll have another small wound, which is the exit, but the burn is internal and kind of blooms outward over time. So what looks like a relatively minor wound initially can be devastating tissue damage in 24 to 48 hours. It's crazy how bad how unimpressive the wounds can be initially and how devastating they actually are. It's unbelievable. But again, the heart is very susceptible to electrical conduction changes, and they've just gotten zapped with some sort of voltage. So you have to watch for cardiac dysrhythmias. It's a huge, big deal with electrical burns. James, or any of the other EMS folks, do you guys ever pick up a electrical burn?
Yeah.
Am I right in saying the wounds that initially can be very unimpressive?
Yeah, the outside may be very, very limited in terms of what you see, but internally you can look at the heart and its dysrhythmia, put them on an EKG, and the heart's going all over the place.
Yep. And again, the tissue itself 24, 48 hours later is just, it's been internally cooked. It's unbelievable. All right, thank you. Cushing's syndrome. So what's that patient going to look like?
Moon face.
Moon face.
Truncal obesity.
Yep.
Osteoporosis.
Yep.
Hypertension, hyperglycemia, red face. Low hair, body hair, stria, red stria.
Mm-hmm.
Yeah.
Buffalo hump. Delayed wound healing.
Hold on, Jack, 1 second. Eugene, you said something about blood pressure.
Hypertension.
Hypertension, right. And I just want to clarify, it's hypertension all the time. It's not intermittent, it's not postural, it's nothing like that. They're just plain old hypertensive. Okay?
Yep.
Thank you. That'll get you out of Dodge. And what is Cushing's disease, if you will?
Too much cortisol moving around.
Too much cortisol moving around, right. And Jack, did I interrupt you from saying something else?
No, it was just a bunch of different things that are on the assessment for them.
Yeah. What's already been noted will get you to the promised land on Thursday, okay? Moving on to Addisonian crisis. I should have a typo there, Addison. What do those patients look like? Especially Addisonian crisis.
It's quite the opposite. the pigmentation, hyperpigmentation of skin,
Yep.
low blood pressure, confusion, lethargy. What else?
With hypotension comes,
Falls.
Dizziness,
Dizziness.
weakness.
yep,
Tachycardic.
tachycardia. I heard you, Jack. How about GI wise? Especially with the Addisonian crisis. They're often nauseous and vomiting. Okay. Diabetes insipidus. What's that patient going to look like?
Excessive
Extreme thirst.
urination.
So they're going to be thirsty. They're going to have excessive urine output.
For natremia.
Keep going.
Extremely dilute urine. And high serum osmolarity.
Correct. And from a physical exam, Jonathan, are they going to look fluid volume deficit, fluid volume?
They'll look dehydrated.
Right. So tell
They'll
me.
be dehydrated.
Please.
Poor skin turgor. Dry mucous membrane. The skin in general might be dry.
Good. Where are our vital signs at?
Tachycardia.
Yeah.
Low blood pressure.
Good. Very good. Thank you. All right. So now we're worried that we've got a patient who's got thyroid problems. Let's start with hypothyroid. What might we see?
Lethargy,
Yeah.
confusion.
Well, let's not go to extremes. Let's start with sort of
Weight gain.
weight gain,
Cold intolerance.
cold intolerance. Good.
Constipation.
Linda, say that one more time, please.
Constipation.
Constipation. Good.
And interestingly, so in severe cases, they have terrible wheezes in their lungs. It sounds terribly like a lung edema. You give them thyroxine in like 2-3 days, they're different people.
Really?
Yes,
Didn't know
this
that.
hypothyroidism, yes.
We haven't gone that far. What's happening to their to their hair, skin,
Very
nails?
dry. And
Everything.
they lose body hair.
Brittle, dry hair.
Right.
And like thick gray skin, so.
And now hyperthyroidism.
Tachycardic.
Heat intolerance. Diarrhea. Hypertension. Weight loss. Tremors. They might have a goiter. Palpitations.
The bulging eyes, whose name I forgot.
Exophthalmos.
That thing. Thank you.
Moist, warm skin, exophthalm.
Two things. You can actually have a goiter with both hypo and hyperthyroid.
Yep.
So a goiter isn't definitive for either one.
But isn't it more prevalent with hyper?
Say again?
Is it not more prevalent with hyper than hypo?
I'm sorry to say I'd have to look that up.
Not exactly, James. So like in endemic areas with iodine insufficiency, so they have goiter, that's where, but it's mostly hypothyroid because they don't have enough iodine. Like
All right.
endemic goiter. So it can be both.
Okay, we'll put it down for both.
Okay.
I just don't want you to think that a goiter is definitive for thyroid problems, but not for hypo versus hyper, as far as I know. And while you get the exophthalmos, you also, with hyperthyroid, you get some other facial changes with hypothyroid.
Venus around the eyes, myxedema.
You get some facial and eyelid edema around the eyes.
And this is for hyper, right?
Hypo.
Or hypo.
Hypo.
So facial changes and myxedema and hypothyroidism.
Hypothyroidism, yep. Facial
Thank you.
edema, eyelid edema.
Do we have to know anything about myxedema coma or thyroid storm?
Not for Thursday's purposes, Jonathan.
Thank you.
All right, so your patient's been diagnosed with SIADH. He's being treated. What's one of the first signs that it's working?
Increase urine output?
There you go. They start to pee. It's a Christmas miracle. Okay. What are the two kinds of diabetes?
Type 1 and 2.
And what's type 1 versus, how do you describe those, James?
Some people might call that childhood diabetes. It's where you need to have insulin added to your body on a daily basis, type 2.
Well, no. Why do they need insulin?
Because the body
Insulin dependent.
Your body's not producing it.
Why not?
The immune system destroys the cells in the pancreas that produce insulin.
Yeah, and those cells are, I could tell you wanted to say the cells, but you just couldn't remember what name.
The islets of Langerhans, right?
Well, even more specific.
Beta cells.
There you go. Thank you. And then type 2 is, again, formerly adult onset, or is a function of what?
Diet and exercise.
Insulin resistance.
Insulin resistance was what I was looking for. Thank you. So in terms of sort of medium to longer term monitoring of blood sugars, what do we do? What do we watch?
A1C.
And where do we usually want A1C to be?
Below 7.
Okay. And what are some of the things, what are some of the physiologic issues that impact patient blood glucose levels?
Exercise?
Yeah,
Stress,
I was
illness.
thinking more illness,
Stress, infections,
Fever?
stress, infection.
increase in cortisol.
Increase in cortisol, Jack. That's interesting.
Or is it something? Is it something
No,
else?
you're right. You're right. So what are some of the ways?
Because when you get a steroid, it can increase it.
Oh, there you go. Beautiful. I'm done here. And if you have a patient who is taking steroids, what's probably one of the most important things they need to know?
Don't abruptly discontinue it.
Taper down and check sugars.
Yeah. That's true too, Jack, but I think Jonathan's point will be more helpful on Thursday.
Mm-hmm.
What was it? To discontinue it?
Don't stop it.
Oh, okay. Thank you.
So if your patient, how do we treat cardiac tamponade?
Pericardiocentesis.
Okay. What's complete heart block look like?
The complete dissociation between the P waves and the QRS complexes.
Yes. And how would you describe ventricular tachycardia?
Regular aberrant QRS complexes.
No P waves.
No P waves, yep.
I always call them wide and bizarre. And what's ventricular fibrillation look like?
Squiggles. No discernible anything.
Mm-hmm. And how about atrial flutter?
Looks like a bunch of sawtooth in between the QRS complexes.
Good. Atrial fibrillation?
Well, inverse of VFib. That's the way I always think of it.
Irregular QRS complexes with no discernible P waves. It might be coarse or fine between the QRSs.
That's true. Just as VFib can be coarse or fine also.
But AFib is around what, 250, 300 on the atrial? Is that right, or I could be wrong?
It's really not discernible, Jay.
Okay.
It's
Irregularly irregular.
yeah. The impulses can it is true that many impulses could get down into the ventricle, and you can get a ventricular response that nears 200, which is, that's where you get that rapid ventricular response, which has to be slowed down. But you're really not able to count an atrial rhythm at all. If you've done a 12 lead EKG and for a patient, and again, we're not talking a rhythm now, we're doing a 12 lead EKG. What should you know, after you take a look at it and you notice changes, what are some of the most important changes that you need to make the team aware of?
ST elevation.
Asystole. VFib.
Well, those are like flat out emergencies, but just notifying the team, I think ST elevation is a good example of that. But to that end, if you found a patient, so Linda, what's another, if your patient's asystolic, what's that mean?
Flatline.
There's no real rhythm. Like there's no actual P waves occurring. There's no QRSs. The heart is not firing.
And beyond,
They're dead.
Or doing a damn good imitation and waiting you to interrupt their imitation of it. And so after you've checked the leads to make sure they are attached and you haven't put them on wrong, and what else are you doing in a somewhat frantic?
Call the code.
Quality CPR.
CPR.
Quality CPR, there you go. Versus discount CPR. Well, you're also, you know, again, you're like, hey guys, can I have some help in here? But you're also, what other assessments are you doing?
Pulse.
Well, you probably checked their pulse and you checked their breathing before you did CPR, right?
Exactly. Annie, are you okay? And then once so again, with all due respect, doesn't really matter what you see on the monitor. No pulse, no breathing equals
Time to
Code.
CPR.
code, CPR, etc. Good imitation of dying. Unless they're do not resuscitate, it's our job to stop the imitation. So, you know, you've been doing, you know, you've got a patient who's pulseless. You've got VTAC on the monitor. What's your next step?
Shock.
Which specific, given that there are, if you will, two kinds of shock, Jonathan, which shock are you going to give to VTAC?
Defibrillation, if it's pulseless.
Correct.
In other words, unstable.
Yeah, that's pretty unstable, that's for sure.
Carol Ann, now
Yeah.
now I got Andy stuck in my head.
Sorry.
No, I love the song. It's okay.
Is the Michael Jackson or alien ant farm? That's the question.
If you've got patients who are having lots of ventricular ectopy, if you will, what's one of the first things you're going to do? What do you think is up, might be up? So what do you, or what might be going on? What are you going to check?
Electrolyte.
Anything in particular?
Potassium, magnesium.
Yes. Potassium.
Drugs.
Drugs prolonging QT interval.
Caffeine, street drugs,
Yeah.
smoking.
And so I heard potassium, I heard caffeine, I heard other street drugs. Any other, what, there's another big lab that I heard magnesium, which
Calcium.
I say not that cardiologists don't care about magnesium, but the pulmonologists really care about magnesiums. What do the cardiologists care a little bit more about than
Calcium?
calcium? Yeah. And I'm sorry, we were talking about atrial fibrillation with rapid ventricular response. What's our goal of treatment there?
Lower the rhythm.
Yeah.
So you give digoxin?
Oh, digoxin's a little old school, James. Digoxin has so many side effects. We've got a lot of other things we can.
You want to give them vasopressin?
Cardioversion?
Well, again, we're going to try drugs first before we zap them. And so
Beta blockers.
the beta blocker for more long term, they'll usually start with cardizem or
Atropine. No, amiodarone, right?
amiodarone, but there's another A drug.
Verapamil.
Verapamil.
Verapamil, calcium channel blocker.
Yeah. Again, verapamil is more for longer term control. It's not really their preference for in the moment control.
Amlodipine.
Cardizem, nah. Amlodipine.
Do you
No,
mean
that's
amiodarone?
what was that?
Amiodarone or amiodarone?
James said amiodarone. Amiodarone, cardizem, and give me a minute, it'll come to me.
It's not atropine.
No,
That would be, no.
atropine speeds the heart up, so that's
Right.
Person
we're
had a cardiac
contraindicated
arrest.
there.
Give them epi and atropine.
Hold on, let me look it up. Drug.
Adamant?
No. It's definitely cardiotoxic to control SVT.
What is it for atrial fibrillation with fast response?
And it's not only, it's for
Supraventricular.
Adenosine.
adenosine. Thank you. That's it. Good job.
Are you referring to SVT or AFib?
Well, adenosine is more for SVT.
Yeah.
But they'll sometimes try it for an atrial control also. Cardizem and amiodarone are your
long-term.
are your the two more common drugs. And then they use beta blockers to if they can't seroconvert you, or if they can't convert you, well, no, they'll give you good metoprolol forever, both to control rate, whether you're in normal sinus or AFib. Adenosine, that was what I was thinking of. Thank you. It's kind of crap that drives me crazy when I can't think of it. Okay. And again, you hope that they're going to convert at some point, but if you can't, at least control the rate. All right. What are some signs of mitral stenosis patient might complain of?
Shortness of breath, fatigue.
Occasions, chest pain.
Shortness of breath, fatigue.
Murmur?
Usually, the shortness of breath usually on exercise.
So DOE?
Yep.
Would they have the symptoms of pulmonary edema, like crackles?
That would be more extreme. Certainly possible, Jonathan, but that's not their sort of initial presentation, hopefully. Hopefully it's been caught earlier than that. And if you do have a patient with mitral stenosis, what's the dysrhythmia of choice with mitral stenosis?
AFib.
AFib, correct.
Dysrhythmia of choice. I like that.
If patient goes on to have a valve replacement, has mechanical valve,
Need to get their INRs checked quite often.
well, we'll go with regularly. Because
Regularly.
Why is that?
They're increased risk for clot, stroke.
Correct. And how do we combat that, Katie?
By giving anticoags.
Right. Good.
But also prophylactic ABX, right?
Yes, but the clots will get them before the infection will.
All right.
Unless they've got a dental appointment scheduled weeks after surgery, but in general,
Okay.
we worry about the clots.
All right.
All right. What's your priority assessments with a patient with a pacemaker? Why do they have a pacemaker?
Batteries.
Nice try.
Their heart's not beating fast enough, typically.
Right. So what's your priority assessment?
Heart rate.
And
Rhythm?
beautiful. What are signs of decreased cardiac output? What are you looking for?
Diaphoresis.
Fluid retention, edema.
Lightheadedness, dyspnea, or shortness of breath,
Uh-huh.
possible fainting,
So
Altered
we've got
mental?
change in mental status. We've got shortness of breath. What's causing the shortness of breath?
You're not perfusing.
All right. When you're not perfusing, excellent statement, James. When you're not perfusing, what's that passive aggressive organ?
kidneys,
And so what are you looking for there?
Increased bone and creatinine.
Oh, even before you're going to see that, Kristen, what are you going to see first?
Decrease urine
decrease
output.
urinary output,
Thank you. What are some signs of coronary artery disease?
Chest pain.
And
Well, you can have a heart attack, right?
right.
Cardiac arrest.
So, well, don't go that far. Let's be a little more optimistic that we can catch them in an earlier stage.
shortness of breath, pain in the arm or shoulder, left side, weakness, nausea, diaphoresis, lightheaded,
Let's go back to the pain. All what you said was all correct, but where else might they have pain?
jaw,
Radiating down their left arm.
That's what
there's scapula,
where does it start often?
In the chest.
Okay. I just wanted to be clear that's not only the left arm or the jaw. And what else is really key about what differentiates unstable angina from acute coronary syndrome, like if you will?
Subsides after exercise is stopped.
It doesn't go away with rest. Is that another way to put it?
It goes away with rest.
Is unstable angina. Yeah,
Stable angina. Unstable doesn't go away with rest. That's correct.
right. Oh, stable angina. You're right. Thank you.
Two sides of the same coin.
If you, yes, for somebody who gets tongue-tied like me. What are
So
some side effects? What was
sorry.
the pain? I'm sorry.
So stable angina is chest pain that goes away with rest. Unstable angina is chest pain that does not go away with rest.
Correct.
Okay, thank you.
So this is a patient that you might administer nitroglycerin to. What are some of the side effects of nitroglycerin?
flushing, headache, dizziness, nausea,
Beautiful.
Blood pressure dropping.
Beautiful. Couldn't write the number down, could you? Yeah, break. Hold on one second, I need to look for something. Okay. So this is more, it wasn't on the blueprint, so I'll send out a note that just what are some of the things that you're going to want to do in the event of a rapid response? You're waiting for folks to come. What can you What do you want to have in the room? What do you want to have for the patient? How can you help get a rapid response rolling? What are some of the things you need?
As a student, get the heck out of the way.
We'll still be watching for
There's a chicken
education.
in every pot, Jack.
Get the board underneath the patient so you can do compressions.
Well, again, don't lose sight. Rapid response is all about early rescue. Rapid response, if I'm not saying you don't put the board down, but the board implies you're starting CPR, which has nothing to do with early rescue.
O2.
With that being said, so think somewhat earlier rescue. What can we do?
Ambu bag.
Code car, ambu bag, OS kit, oxygen.
You're in a hospital. You're gonna. Oh, wait a minute.
The code card.
IO kit.
Yeah, the IO.
Yeah, you're in a hospital. I'm gonna bother with an IO kit.
That's what we run to get.
Really?
That's what they did, yeah.
It's the quickest way to get the fluids in. Way faster than doing an IV. You can just drill down, just zip, you're in. Carolyn,
Well, let me tell you, people's IV insertion skills have declined since my day.
Well, a lot of these older folks getting a good line is really hard. You know that.
Wouldn't a patient that unstable already have an IV?
Simulate a rock. I don't even want to tell you where I've put IVs in my day.
Imagine with IV drug users under the tongue, like all sorts of things in between
I
the
never had
toes.
to go under the tongue.
Oh, Mom told me about that.
Much more personal and would make the men on this call a little queasy, if you know what I mean. All right, so let's establish IV access one way or another. IO, for the love of Christ.
Protect the airway, so.
Yep.
might
What
need-
other equipment do we need?
You need your defibrillator at some point.
Yep.
Intubation kit.
Should be nearby. Yep.
It's going to be in the crash cart.
Good. Yeah, a lot of that stuff is in the code cart.
Suction.
Suction. Good.
Intubation.
What was that, Jack? James, I'm sorry.
Intubation.
That's in the cart. We
Yep.
got it.
Meds. You're going to need epi. Going to need your.
Those are all in the cart.
all right.
Everything except your narcs are in the cart.
Got a set of vitals.
Yep. So how are you going to get those vitals? How are you going to? What else is usually attached to the defibrillator? What if you're not using it as a defibrillator? What are you going to use it for?
Cardiac monitor.
Cardioversion.
I was thinking going for cardiac monitor. And it's crazy in this day and age. But what's one of the other things that's got to be nearby?
Emesis bag.
Well, we used to run and get the chart. What do we run and get now?
Oh, wow.
The cow.
Yeah.
The cow or the wow?
No. Never the cow. It's a wow now.
Wow.
It's
Much
the
more than a
wow.
computer.
Do you know why that was changed? They were initially cows.
Patients thought you were calling them cows.
That's true. Yep. So they are now workstations on wheels. Wows.
Yale New Haven hates the term cows.
Every hospital should. Because again, I'm telling you guys, one of the first things I told you was that patients hear everything. We are the best show in town. We are very entertaining. We are real life Chicago Hope, and whatever other, they're always waiting for Patrick, what's his name, or George Clooney to walk in.
Dempsey.
Dempsey, that's it, thank you. All right. Any outstanding questions?
Do we know how many dosage calcs we're gonna have?
There should be 5.
Anything special about the dosage calcs or just the usual?
Quite straightforward.
Thank you.
And is it 75 questions?
Yes, it is.
Okay. Thanks.
What time? 8:30?
9 a.m.
9 a.m. Okay, thank you.
Oh, that's a lovely view.
I hope.
Did anybody lose power last night? Was everybody okay in last night's little blow?
I
Linda
lost
last
it.
hour.
Thanks, John.
Who was that lost it? Was that
I did.
Katie?
No,
Or
Linda.
Kristen? Oh, Linda?
No, but I did tonight.
Seriously?
I lost
I
it too, but
know.
only for like 3 seconds at a time.
Oh,
Oh, I
Yeah, I
for
was
like 3
flickering too.
hours.
I lost mine for
I
a
just
few
got
hours.
it back on.
oh, well, I'm glad you did. And Linda, how long were you out for?
A few hours last night.
It was.
I think a tornado touched down where I grew up, where my mom lives. There was a bunch of trees down again. They hit the power lines.
Yeah. Well, hopefully we'll make it through to the weekend. And all right. Well, you guys know where to find me if you have any other questions.